So my name's Amanda Stafford. I'm an emergency consultant at the Royal Perth Hospital, and my interest, in fact, in homelessness came about because of my interest in emergency department frequent flyers, people who come over and over again to the emergency department. And by looking at those more closely, came to realise that homeless people are, in fact, the majority of our frequent presenters to the emergency department, and that led me on to working with other agencies, other people, in order to try and get a better way of looking after these people. And what that's led us to is, as Stephen Hall has said, is the Royal Perth Homeless Team, which is a collaboration between the homeless healthcare GP practice and Royal Perth Hospital. And we're also both tightly linked into community services such as the 50 Lives, 50 Homes program, which is coordinated by RUA, to try and house in a permanent fashion the most complex and chronic homeless people. What that requires, as our Minister of Health also pointed out, is multi-agency approach, and also the next stage, which is what this is about, which is breaking down government silos, because single departments cannot in fact solve this problem. But we are in times of tight fiscal restraint as well, so I'm going to give you a good news story here about why actually it does work in this era. So let's have a look here. So I'm just going to give you a few facts here. So we have about 75,000 presentations a year, and we saw last year, 2016, 926 homeless individuals. Now we see the majority of the homeless people within Perth. The other two tertiary hospitals have about 700. Now, they don't actually represent a huge percentage of the population of our ED presentations, but in terms of frequent presenters, they're most of them. Because one of the things that I came to realise is that if you have something like this, a hospital can fix it. Somebody's in a motor vehicle accident, we love that. We just love that. We're in there, resus, get all the equipment out, off to theatre. This is what we're not so fond of. Because the problem is that a hospital doesn't actually have any good way of dealing with somebody who has this sort of problem. So these are the ones that we groan at, because we don't know really how we're going to make things better. Because we can patch up this gentleman's injuries, we can treat his pneumonia, but when we put him back out the door into homelessness, the same thing is going to happen again. And so that's where the impetus came from, trying to change things. So we collected some data from the homeless team to show you. So we took, in the first 6 months of the operation of the homeless team, we saw 300 no fixed address patients. So that's 300 individuals. And then we said, okay, so the fact that they're homeless, what have they been doing before we even started the homeless team the year before? So we looked at all of these sort of parameters of hospital usage. And these are the sort of costs in 2015. They're actually more expensive now, but you're probably quite surprised at how expensive it is to actually be in a hospital or visit an ED. And so what we did is added up in 2015, how much hospital healthcare did these people use? And the answer is $6 million worth for people with an average age of 42 years of age. And the year after, they're being seen by a homeless team, because they're still homeless, or they are homeless now. And this is quite shocking. 42-year-olds would not be expected to be using this level of healthcare, but that is the fact for this cohort of people. And we did another, which is we took 7 complex individual patients. They're homeless. They have a mixture of usually mental health, medical problems. And we had a look and these are patients who are treated like they have a medical problem. So their social problem, which is their homelessness, is not being addressed, and they keep being admitted over and over again. And we stacked up how much hospital care they used in 1 year, and that was $194,000 each. And if you compare that to the cost of a rental, we're looking at over 10 times the cost of it. So this is an astounding amount of money. This is what hospital administrators would be doing if they actually extracted the data from them. But this is the usual response. When you say we've got a problem, these individuals are costing us a lot of money, and administrators, they go, but we don't have money, or it's not our problem to deal with. But in fact, we're already spending a lot of money on them. We're spending a lot of money, and it's unlimited as well, in hospital health care for these people. You get very sick, you go to intensive care, but you're put back out on the street because there's no available housing. You come in over and over again with infected wounds, you're put back on there. You have mental health problems, it's too hard. So actually what we're doing is this, with that money, is because it's not actually changing people's outcome. So it comes down to, so this is the argument that's usually used, but look, if we helped all those people, but we'd still fill every hospital bed, so what difference does it make if we do that? And the answer is, well, what do you want to spend it on? Things like this, because hospital and medical care can be the definitive treatment for many problems. If you've got an arthritic hip, then a hip replacement will help you. If you have appendicitis, then an operation will help you. If you have a mental illness such as depression and you're not homeless, then the mental health, some antidepressants and maybe a short hospital stay will help you. The problem is that what we're using it on is we're just wasting it. We're not actually addressing the fundamental underlying problem, because this is in fact the best healthcare that you can provide for homeless people. You have to twin it with that, with the support to keep people in housing, to help them to adjust to housing. And that's it. Thank you very much.